A very good evening and a warm welcome to all our viewers. I'm Dr. Shatil from the Clinical Engagement team here at DocPlexus. Welcome to our special webinar on Is surgery the most effective treatment option for diabetes? Nearly all individuals who have had surgery to treat diabetes show improvement in their diabetes, sometimes as quickly as few days after surgery. They experience lower blood sugar levels, need less diabetic medications, and see an improvement in diabetes-related health problems. Diabetes surgery performed today has been highly refined over the course of past 70 years and is among the best studied therapies in modern medicine. To tell us more about this, we have invited Dr. Ramen Goel. Dr. Ramen Goel is a diabetic and metabolic surgeon with extensive experience in diabetes management. His study on SGIT for diabetics has been internationally recognized. He is the first Indian metabolic surgeon to receive the US acclaimed Surgeon of Excellence certificate. We welcome you to DocPlexus, sir. I would now request you to go ahead with your presentation.
Good evening, friends. It's an honor to be on this platform once again. Diabetes surgery has been in news for last 2.5 months, and there's been much discussion about this in media and in medical fraternity alike. There have been many speculations, doubts, and appreciation of what we have introduced. There have also been some criticism that this surgery is nothing new. It's a type of bariatric surgery. So I thought it's the right time that we discuss the evidence that supports why surgery is considered the most effective therapy for diabetes. And so I'll start my presentation, and at the end, I'll be very happy to take questions. You can share questions with DocPlexus, and Dr. Shatil, who is moderating this program, will be asking those questions to me, and I'll make sure that every question is answered. So give me a second. Let me start my screen share. So friends, greetings from Center for Metabolic Surgery, which is at Wockhardt Hospital, Mumbai Central. And the topic of the day is diabetes surgery, what in scientific term is also called metabolic surgery. I am director of their program at Wockhardt Hospital. I am also founder editor of Journal of Bariatric Surgery in India, from India, and I've been president of IAGS. Now, as you can see, the diabetes surgery terms arises from metabolic surgery. Why we cannot use this bariatric term is because bariatric applies for baros for weight, and the term applies for treatment of obesity. And bariatric is a scientific term, and it's used popularly as obesity surgery. Even the journal which is published for bariatric surgery is called Obesity Surgery Journal. So when it came to treatment of diabetes through metabolic surgery, the layman term has to be diabetes surgery, and that's how this term was coined and is being popular now. Diabetes, as you all are aware, is a very common disease. It's a major problem. Almost 8 crore Indians have diabetes, and almost 77.6% of them remain uncontrolled, despite taking medicines, lifestyle measures, and all education that goes with it. Now, the problem is not the raised sugar, but if the raised sugars remain for a long time, then there is a likelihood of having more complications. And we all know that neuropathy, retinopathies, cardiac problems, renal problems, brain strokes, etc., etc. The cost of diabetes management, along with its complications, is almost $31 billion as documented in 2017. And it is also said that diabetes alone exhausts up to 25% of average household earning in a year. So I think it's very important to realize that diabetes is a major problem. Like many other diseases, like cancers, like cardiac disease, now surgery is also one of the treatment options. Like in cardiac disease, coronary bypass graft surgeries or angioplasties is one option while the medicines still remain. Similarly, now diabetes has another treatment option besides medical management and lifestyle changes. And I'm going to talk to you in next 15-20 minutes about that. So what is diabetes surgery? A lot of people said that, diabetes surgery is nothing else but bariatric surgery. Absolutely correct. This is bariatric surgery. So surgically, the surgical technique is the same as bariatric surgery. But something has changed over the last 3 months, and that's why we are discussing this today. So what has changed? Now we are able to offer this surgery only for diabetes, even in patients who are not obese. So the guidelines that have changed as recently as this published publication in December 22, about 2.5 months back, the guidelines changed that for Asians with BMI 27.5, we can offer this surgery for uncontrolled diabetes. Now, realize the implication of this. Up till now, we knew that bariatric surgery can be done for obesity. And obviously, some of those obese people also had diabetes, so they benefited from it. Now, first time in last 30 years, or let's say centuries, we are in a situation where it is said by international guidelines that we can offer this surgery only for diabetes. So if a patient with 28 BMI comes to my clinic and says, Dr. Goel, I'm not very happy with my weight, please do a bariatric surgery, I will have to refuse because the lowest BMI for obesity is 30 for bariatric surgery. But if the same person at 28 BMI comes with uncontrolled diabetes despite medical management, I can offer the same surgery for diabetes management. So friends, it's important to realize that the difference is that now this surgery, which was earlier called bariatric surgery, can be offered exclusively for diabetes. Anybody above 27.5 BMI, whatever is the BMI, if he has a diabetes, uncontrolled diabetes, we can offer this surgery. So this has changed. And this has not changed overnight. In 2011, International Diabetes Federation published a paper in Diabetes Care where they said that this surgery should be offered in Asian patients with 27.5 BMI because we are at very high risk of diabetes-related complications at low weight. Nothing changed after that. We continued to offer it above 35 BMI. Then American Diabetes Association in 2021, I put the publications here. 2021 Diabetes Care mentioned that the surgery can be offered for Asian Americans if their BMI is 27.5. For non-Asian American, it was still 30 BMI. It still is 30 BMI. But for Asian Americans, it can be offered at 27.5 BMI. Same thing is also followed in UK. If a patient goes through for 28 BMI or 27.5 BMI with uncontrolled diabetes to NHS, they will do the same surgery. They will offer the surgery. But if a Caucasian British person goes to NHS with 28 BMI, he will not be given this surgery. He will only be given this surgery above 30 BMI. So I think these were the two medical associations, largest associations worldwide, which endorsed this in 2011 and 2021. But still, surgeons were not doing this surgery, and we waited till the guidelines changed internationally in December 22, which is only about 2.5 months back. Another thing that we need to realize as physicians is that diabetes remission has been defined. And diabetes remission is if the patient is not taking any medicines for diabetes and is maintaining his HbA1c below 6.5 for at least 1 year, then it is partial remission. And if the same person is maintaining HbA1c below 6 without medicine, then it is called complete remission. Now, this is generally not possible with medicines. Remission is not possible with medicine generally, because if by medicines you bring down the HbA1c below 6, then the condition of remission is that they need to stop the medicine for at least 1 year and still maintain HbA1c below 6, which is not possible. So remission only is possible, generally speaking, after a surgery. And I'm going to mention to these definitions repeatedly during my presentation, so please keep a watch. Now, what happens after surgery? After diabetes surgery, 80% of patients have complete resolution. That means their sugars are normal without medicines, even after 1 to 2 years of surgery. And 36% of these patients will remain off medicine even 10 years after surgery. That means if 1 in 3 patients who will undergo surgery for diabetes, even after 10 years, almost 36% of them will not require medicine. And obviously they don't require medicines because the sugars are normal. Nobody will stop medicines if sugars are raised. So I think this is the kind of difference. On one side, we are looking at 77% of patients who will remain uncontrolled with medication. On the other side, we are looking at almost 1/3 of the patients, even after 10 years, will remain very well controlled and off medicine, while 80% at 1 year will remain off medicine or very well controlled. Now, we have published our own data on diabetes remission. So look at this. The first study that we published, which was 3 years follow-ups of our patients, and we have shown that 80% of sleeve gastrectomy patients will remain off medicine even after 3 years. And almost 92% of diabetes patients will remain off medicine even after 3 years. The same patient set was followed and published after 5 years, after another 2 years. And this sleeve patients, 64% of them are still off medicine 5 years later. Okay. And then we followed up another study of the same group at 7 years. We are now collecting data of 10 years follow-up, which will hopefully publish very soon. At 7 years, it shows that 32% of patients are off medicine and HbA1c below 6. And another 22.6% patients are HbA1c below 6.5 without medicine. If we join these two groups, you will realize 55% of the patients, even after 7 years, are HbA1c below 6.5 without medicines, which is substantially good. And another 13% patients are maintaining HbA1c below 6.5 with medicine. So if we join this, 68% patients, even 7 years after surgery, are maintaining HbA1c below 6.5. And this is what we need to realize the difference, because we are ultimately treating patients. Ultimately, we need to see what treatment helps a patient. It's not a question of who is treating, whether a physician or a surgeon. But if those patients who are not doing very well with medical management and lifestyle changes, surgical help can be sought and offered to your patients. So the question came, this will not work in slim patients. I got a WhatsApp message from a physician saying he has been told that this will not work in non-obese patients. So let me share some data with you. So this study, which came from Cleveland Clinic, has said that when they compared the high BMI and low BMI patients, they said the impact of surgery is same in patients, whether they are high BMI or low BMI. This study, which is published by Dr. Shah from Pune, says that there is substantial improvement in those patients below 35 BMI. And then there is a meta-analysis which was published, which says that The benefits of surgery are BMI independent. And this is important, and all the guidelines which I already mentioned support the use of metabolic surgery or diabetes surgery in low BMI patients with poorly controlled diabetes. Now, what is this surgery? I'm sure all of you have attended multiple talks on bariatric surgery. The surgeries are the same, whether it's sleeve gastrectomy, whether it's gastric bypass or mini gastric bypass. And primarily they work by the fact that food reaches the ileum, terminal ileum faster than in those who don't have the surgery. So whether it's a sleeve, the stomach empties faster and food goes faster, or whether it's one of the gastric bypass, food is reaching the terminal ileum faster. And that is why there are hormonal changes, which I'm going to discuss. Now, as all of you know, these are keyhole surgeries, takes less than 1 hour most of the time. Since it's a laparoscopic surgery, patient can walk and drink 6 hours after surgery, usually 2 nights hospital stay, and they are able to resume work within 4 to 5 days. How does it work for diabetes? Because the food is delivered early in the intestine, there is enhanced secretion of GLP-1 hormone. All of us know GLP-1 hormone because now this is medically available in the terms of semaglutide and liraglutide, those products. And once the hormone is secreted, hormone works on pancreas and peripherally. It reduces insulin resistance, increases insulin production, and it is also believed to increase number of beta cells in the pancreas. There are other mechanisms also like change of gut bacteria, calorie restriction, but the very fact that the impact of surgery is seen within 2 to 3 days justifies that it is because of the hormonal changes, and there are multiple studies which have shown the enhanced secretion of GLP-1 after surgery. So friends, is this surgery for everyone? At the moment, the selection criteria with the new guidelines, just 2.5 month guideline, is that the BMI should be more than 27.5, which in layman term, to explain to a patient of yours, that the patient should be around 8 to 10 kgs overweight. So if the patient is more than 8 to 10 kg more than the ideal weight, then maybe we can, he or she is a good candidate. Then patient should be on adequate medical treatment. I'm getting patients who have never taken medical treatment, who are on Ayurvedic treatment, or who have never taken medicines and they want surgery. They don't want surgery. It's little tricky and should not be offered because this is the requirement. And obviously, patient should be safe enough for anesthesia and optimized for anesthesia. Why this is important? Because it has been published somewhere in 2016 that for every year of remission, the risk of microvascular disease reduced by 19% compared to those patients who never had remission. So I think we are talking of remission for 7 years, 10 years, all right? And thus it is important to realize that the risk of microvascular disease will reduce many-fold in these patients. And I'll show you some direct evidence to that effect. Look at this study where they had a group of patients who were managed medically, matched group, managed medically, and another group which was managed after surgery. And they followed these patients for long term. They found out that macrovascular events reduced by almost 75%. In the control group, they continued to in about 9.7% versus post-bariatric group, where it continued in about 2.1% patients. So the myocardial infarction reduced from 1.8% to 0.3%, strokes reduced from 1.6% to 0.4%, and the related deaths reduced from 7.5% to 1.6%. The effect was more drastic on microvascular events, where it reduced by almost 90%. So 2% in control group versus 0.2% in the surgical group. And This is the most, and there are many other publications which have shown its surgery's impact on diabetes complications. And because that happens, and obviously it's a same surgery as diabetes surgery or a bariatric surgery, sorry. So the other benefits like resolution of hypertension, triglyceride reduction, risk of myocardial infarction reduces by almost 50% at around 11 years after surgery. So friends, because of all this, again another study has shown that 10 years after surgery, there is 40% reduction in all-cause mortality and 56% reduction in mortality due to heart attacks. Now, these are substantial numbers, and based on these kind of evidence, the International Diabetes Federation and the American Diabetes Association have made these recommendations of offering surgery even at 27.5 BMI, even if the person cannot be offered the surgery for weight loss at the same BMI. So now these surgeries are diabetes surgeries. The surgical technique may remain the same, but the indication have completely transformed. And that is why the discussion today. Another study which was published in Lancet has shown that those patients who get this surgery for diabetes, the average life expectancy increases by over 9 years. Now, which other intervention increases the life expectancy by so much? So this goes on to show that diabetes reduces the life expectancy, and if the diabetes is well controlled, the life expectancy is likely to increase substantially in these patients. I am at the end of my presentation. I'll just show you a few patients whom we have operated recently after these guidelines changed. This gentleman, 64-year-old, just 84 kgs, diabetic for 14 years, on OHA and insulin, but still HbA1c was 9.35 and his postprandial sugar was 358. He lives in Mumbai, highly educated person. We did his gastric bypass on 19th of December. He was the first patient to undergo this surgery under the guidelines, new guidelines. His insulin stopped on day 2, and now he's only on 2 diabetes medication and sugars are normal. I'll show that. This lady who is again 50 years, just 87 kgs, diabetic for 6 years, on 4 drugs, oral hypoglycemic and insulin, 5 drugs, and she's a healthcare worker, a nurse in a BMC hospital, HbA1c of 15, fasting sugar of 240 and postprandial sugar of 454. She had a surgery on 24th December. Her insulin is stopped on day 3 and she's on diabetes medication and her sugars are absolutely normal. She came today to the hospital. Her fasting sugar was 91 and her postprandial sugar was 120. For last 2 months, she has not taken even a single shot of insulin and she's only on oral hypoglycemic. This lady who came from Jharkhand, 53-year-old, 74 kgs, diabetic for 11 years, HbA1c 9.5, fasting sugar 224, postprandial sugar 350. Again, she was on oral hypoglycemic and insulin. Gastric bypass done on 26 December. Insulin stopped on day 3. She's on metformin and sulfonylurea, and sugars are very well controlled. This lady, again 53-year-old, she's a psychologist in Mumbai, 73 kgs, diabetic for only for 1.5 years, HbA1c 7.3. She was on oral hypoglycemic alone, and she went for bypass because she read through the literature before coming to us and said that she has read that if you can't get it done early, the possibility of remission is higher. And she got it done, and after surgery, now it's almost about 2 months or 1.5 months. She has not taken a single oral hypoglycemic, and she conveyed to me yesterday that her HbA1c has come down to 6. So these are the kind of results that we see. I'll show you a few graphs. These are all of those 4 patients. These are their fasting sugars. This is 1 month value because, we collated this data in January, and their sugars from 240 to 132, fasting 224 to 129, 184 to 120, 146 to 112. Postprandial sugar 454 to 116, and likewise, all of them had significant drop on their fasting and PP sugars. Now, HbA1c is an average sugar. So when we see it at 1 month, this is also 1 month follow-up. We see 1 month of post-surgical and 2 months of pre-surgical blood sugar. But look at this, the lady from Mumbai who works from BMC, her HbA1c in 1 month dropped from 15 to 10.5. When we will do it at 6 months, then it will be truly reflective of the impact of surgery, and it will be somewhere between 6.5 to 7 if she maintains the post-operative requirement. So, friends, I know there is a lot of skepticism. It may be arising out of ignorance of the changed guidelines, but the hardcore data is there. We surgeons, bariatric surgeons, were fully aware of this data for last 15 years, and as it was evolving and getting published. But the guidelines did not allow us to operate these patients under 35 BMI. I did a clinical trial and under the ethical committee approval and published it also, but in low BMI patients, but otherwise in clinical practice, none of us were doing it. Now a time has come that this can be offered to patients in clinical practice, and they can benefit from this. There is one more thing that I want to discuss, since all of you are physicians here. These kind of data brings new understandings of diabetes, new understanding of diabetes management. This is a report of that patient who is a psychologist 1 month after surgery. Look at whose HbA1c is now 6. Her fasting sugar 1 month after surgery was 112, but her PP sugar was 89.7. Now, these patients typically will have lower postprandial sugar compared to the fasting glucose. Why? Because glycemic control now comes with eating. Only when they eat food, GLP-1 is secreted and insulin resistance reduces. And that's why we tell the patients to have frequent meals. So if they were having 3 meals a day earlier, now we say you have 5 to 6 meals a day, because that will bring down sugar even better, lower. And this is important to realize that, a patient who's fasting, whether for hospitalization or for religious reasons, the sugars can go up in these patients. But if patient is normally eating, the sugars will also, if somebody gets hospitalized and kept nil orally, then it's a good idea to check their sugars, that you might find the sugars have gone up. It's also important to realize is that if somebody has an infection in the body, the patient's blood sugar may be normal. Patient may say, I don't have a diabetes, because patients started claiming that they have been cured of diabetes. No doctor, no sensible doctor, whether it's a surgeon or physician, will make such a claim. But patients start believing that. So if somebody has undergone a surgery and says and sugars are normal, and if there's an infection, it's a good idea to check sugar. If sugars are high, anti-diabetic medication can be started till infection is controlled, and you will find the sugars are normal again. Then there is another thing that we realized, that surgery offers a meal size related GLP-1 response. What I mean is, if a person has a smaller meal, obviously the GLP-1 response will be less. If they have larger meals, so that means it's more physiological compared to a fixed dose regime that we have been using on our diabetes patient, whether it's oral or injectable, daily injectable, or once a week injectable. Here we are in a more physiological zone as far as patient is concerned. Now, Another question that was asked to me was in last 2.5 months, what happens in long term? How long they will be maintaining their blood sugar? I have already shown data that we have published and international data which says that majority of them will maintain their blood sugar. 1/3 of them, even after 10 years, will not require medicines. They are still in remission. But if you want your patients to maintain blood sugar, ask them to eat meal frequently. I've already explained that. Second thing, the patients come and say, now my diabetes is gone. Can I have sweets every day? Now, just because the surgery has been done, that doesn't give them the license to eat wrong foods. They must continue to maintain their diabetic diet. Now, what is the advantage? The advantage is if they continue to maintain their diabetic diet, they may remain in remission for a longer period, or they may remain under control without oral hypoglycemic for a longer period. So, as any sensible patient who understands this will probably follow this and will have better outcomes in long run. As we all know, physical activity reduces insulin resistance. So if the patient is ready to be physically active or do exercises, that will help. And we insist that they must do their HbA1c once in 3 months. So somebody wrote me back, you are saying that diabetes will improve after this. Why you are getting HbA1c done every 3 months? Please realize these patients have been pricking themselves every day to check their blood sugar. Now I'm simply asking them to check it once in 3 months, because in case the glycemia increases, they should know it. They should not remain uncontrolled. They can improve their diabetic diet, or they can take oral hypoglycemic, and that's a. So I think these 4 things, if they are followed, the patients will maintain long term. A lot of patients who have no idea about our history of bariatric surgery, they come and they discuss about the safety of surgery. Please realize this is not a new surgery. Worldwide, it's happening for 60 years. I'm personally doing it for 22 years. And we have been operating on heavy patients like 150, 200, 300 kg patients, which are very challenging. Now, when I'm operating them at 70, 80 kgs, my anesthetists are comfortable. And obviously, there are no guarantees in surgery, but comparatively, it should be they are much more comfort for surgeon. There is published data to say that bariatric surgeries are less risky than gallbladder surgery or a lap cholecystectomy as far as perioperative mortality is concerned. So I think surgical safety is an issue which is discussed always in terms of bariatric and metabolic surgery. But please realize things have changed. I have seen that change in last 22 years. Technology has improved, anesthetists have improved, anesthetic drugs have improved, and post-op recovery has drastically changed in last 25 years. So friends, somebody asked me, how can you offer surgery for a medical disease? I don't think a disease is categorized as medical and surgical disease. A disease is a disease, and it can be managed medically, surgically, or both. I think diabetes is one disease which will require a multidisciplinary management. And what was missing there up till now has been added with these change guidelines in last 2.5 months. Diabetes surgery is certainly not a substitute for medical management and lifestyle changes. And why so? Look at this study, which was a news item in April 2017, which says India has 72 million cases in 2017, which are likely to double by 25. So if this news is correct, and even if every bariatric surgeon, we are about 400 of us in the country, if all of us start performing at least one diabetes surgery a day, we'll probably be doing about 1 lakh of surgery a year. But by the time, the number of new patients which will be added will be almost 10 million. So I do not think surgery can replace medical management or lifestyle management. Surgery cannot manage even 1% of total diabetic load in this country in next 10 years. So this surgery is only for those patients, I keep on emphasizing, who are finding it difficult to manage, their diabetes, who have a family history of diabetes complications, early age heart attacks in their parents or renal failure, or they already have one of the two complications. So I think it's a good idea to consider this surgery. You may or may not refer a patient to a surgeon, but please look up at your own family members or friends who are uncontrolled diabetes. At least discuss with them, offer them this option, and see that they benefit from this. So friends, to conclude, surgery cannot cure or eradicate diabetes in anybody's body. No surgeon will make a claim like that. Surgery is an effective treatment option for selected patients, as we have discussed. It offers long-term glycemic control. Concurrent medicine stoppage is an additional benefit. Surgery targets glycemic control. Surgery doesn't target medicine stoppage. So when we operate these patients, they are from different cities and different countries. Their physicians will automatically start reducing medicine or stop medicine if sugars are normal. So our purpose, our job as a surgeon is to make sure that the person gets glycemic control. There is significant reduction in diabetes complication and related mortality. There is enough published data, and we can share the data with any one of you, the publications also. But please do not go just by logical thinking or hearsay, because I am getting such kind of messages from all over the country. I have never faced this kind of situation ever in my life, in last 35 years of my surgical career, that somebody believes that we are misleading people. We are giving factual information, and the same people have been part of various guideline creation worldwide, and that's why this leads to increased life expectancy. So thank you so much. I have a brief patient's testimonial which I will play out now, and after that I can see Dr. Shithil is already ready with his questions. I'll be very happy to take his questions and answer them. Okay. Dr. Shithil, it says that I have to enter my password to allow this. What password is this? Is this my...
Maybe we can, okay, it's showing right now.
मी स्वतः बीएचसी मध्ये सिस्टर आहे, ॲज अ स्टाफ नर्स म्हणून काम करते. आता जवळजवळ 2 ते 3 वर्ष माझं डायबिटीज खूपच हाय होतं. म्हणजे ॲक्च्युली मी फूडी आहे, मला खाण्याची प्रचंड आवड आहे. वडापाव, समोसा पाव, फ्राईड वस्तूंची पण पहिल्यापासूनच खूप आवड आहे. आणि आता या 2-3 वर्षामध्ये पहिले सुरुवातीला टॅबलेट मॅनेज होत होतो, पण नंतर टॅबलेटचा काही इफेक्टच होईनासा झाला. मग मला माझ्या डायबिटीसच्या डॉक्टरांनी इन्सुलिनवर शिफ्ट केलं.
This lady came to us with a history of diabetes. She's been trying desperately to control her sugars. She's not a lay person. She's a healthcare worker working in a hospital in Mumbai. And she was taking 5 medicines, including the insulin, almost all possible medicines that are available for diabetes. Her fasting sugars were around 240, and after meal sugars were around 400 plus. Her 3-monthly HbA1c was 15, and thus she was really desperate to get the sugars controlled. So we thought that this will be a good patient for surgery. Anybody who is uncontrolled with HbA1c more than 7 is a good patient. So we offered her surgery in last week of December.
सर्जरीच्या आदल्या दिवशी फक्त मला इन्सुलिन दिलं. सर्जरी झाल्यापासून एकही दिवस मी इन्सुलिन घेतलेलं नाहीये. एकदम शुगर नॉर्मल आहे. गोयल सर तर द बेस्ट सर्जन. त्यांच्याबद्दल तर बोलायलाच नकोय काय बाकी. फार छान. मला त्यांच्याकडनं खूप छान एक्सपिरियन्स आलाय. आताशे मला 18 डेज झाले, पण मला पूर्ण कॉन्फिडन्स आहे की बिटवीन 2 ते 3 महिन्यात माझा पूर्ण डायबिटीस जाईल म्हणून. फक्त सरांचं एकच अट असते की ते सांगतात त्याप्रमाणे सगळं फॉलोअप करायचा आणि त्यांनी सांगितल्याप्रमाणे सगळं डाएट वगैरे व्यवस्थित केलं तर तुमचा डायबिटीस पूर्ण जाईल. आणि माझा विश्वास आहे की जाईल माझा डायबिटीस म्हणून.
3 days later, she went off insulin because her sugars became normal. Then she was discharged from the hospital. And 10 days later, she's only on one medicine, one tablet, one type of tablet daily. And her sugars have come down to 140 fasting and 170 after meals.
वजन पण जवळजवळ आता 18 दिवस झाले सर्जरीला. वजन माझं जवळजवळ 7 ते 8 किलोने कमी झालेलं आहे. मला स्वतःला फ्रेश वाटतं मेन म्हणजे. आता भुकेवर खूप कंट्रोल आहे. चालताना वगैरे पण असं पहिलं जरा हेवीनेस वाटायचं, पटकन स्टेप्स चढताना दम लागायचा, उतरताना असं दम लागायचा, ते आता अजिबात नाही. हॉस्पिटलबद्दल सांगायचं झालं तर खूप छान हॉस्पिटल आहे. हॉस्पिटलला ऍडमिट झाल्याच्या नंतर रिलेटिव्हला राहायची सुद्धा गरज नाहीये. एवढ्या छान स्टाफ आहेत सगळ्या. तुमच्याबरोबर नाही नातेवाईक आला तरी काही प्रॉब्लेम नाहीये. तुम्ही एकटे येऊन मॅनेज करू शकता आफ्टर सर्जरी पण आणि इन बिटवीन सर्जरी सुद्धा. माझं स्वतःचं असं पर्सनल मत आहे की ज्यांना माझ्यासारखं सिव्हिअर डायबिटीस आहे त्यांनी खरंच मला ज्यांनी विचारलं त्यांना मी सगळ्यांना एक सर्जरी व्यवस्थित एक्सप्लेन केली. इफ पॉसिबल तुम्ही जर बाकीच्या सगळ्या बाबतीत फिट आहात तर खरोखर करून घ्या.
So friends, that is diabetes surgery for you. There have been many changes that we had to do from bariatric when we moved from operating on obese patients to non-obese patients. The entire program changed. I think guideline change was a very small component. We had to change our dietary protocols, our medical protocols, follow-up protocols, and we are in the process of laying down guidelines for follow-up of these patients, which I believe surgeons, at least from this country, will benefit. So I think this is what I wanted to say. I'll be very happy to take questions. Dr. Shetil, do we have any questions?
Hello, Dr. Raman. Yes, we do have question. And first, I would like to thank you for that wonderful session. And yeah, so let us move to the first question. So it was absolutely wonderful listening to you. Very well presented session. And I am sure the audience has a lot of takeaways from this session. So I would now request the audience to go ahead and fill in the chat box with more questions. And we'll ensure that all the questions have been answered by Dr. Raman. So with your permission, let's go into the first question. My first question to you is, so this is from my side. So I wanted to know what difference is there in the setup. So from a bariatric surgery to a diabetic surgery.
I think the difference is phenomenal. As I mentioned at the end, the whole approach has changed. When we were doing bariatric surgery, the entire emphasis was to make sure that the patient loses weight. Now, when we are operating on slimmer patients, I mean, many of us are more than 27.5 BMI, so we know that we are not heavy. And the emphasis is completely now on that they should not lose weight. So the dietary changes have been made significant, and there are no international guidelines on this. So that how do you manage patients who should not lose weight? So this is one part of it. Then second part is many of these patients are coming with multiple comorbidities, like they have nephropathy, they have peripheral neuropathy, and or they have heart problems. So more closer interaction with physicians, cardiologists, anesthetists, to see that they don't get any drugs or any intervention which will make things worse for them. And then third thing is the answerability is much higher. You won't believe how much criticism and how many questions have been raised in last 2.5 months, as I said, that people even started doubting your integrity, that you are probably misleading the population. But please realize we are only men of science. Why should we mislead at this stage in our career? If you are not aware of the recent publication, in which I forgive them who are ignorant about it, it's understood, because I don't read publications of other specialties. So we need to spread the word, and I thank Doc Plexus for giving this platform, because we wanted to reach a large number of physicians and other specialists to understand. It's a concept change. I think it is as big a development as introduction of insulin, which happened in 1921 for diabetes management. That now we are in a situation where we can assure the patient that if you just follow the dietary lifestyle, you can maintain their blood sugars. These are helpless and desperate patients whose blood sugars are 9, 11, 13, 15, like this lady. I have right now a patient admitted in my hospital who came for surgery, whose surgery was today morning. And when preoperatively we did her sugar, it was 500 fasting and 600 postprandial. And she has been on insulin. There are hundreds and thousands of patients moving around this country who are uncontrolled diabetes of this nature. I'm not talking of 150, 180 sugar. I'm talking of 300, 400, 500 blood sugar. So I think we are in a very difficult times, because there are so many patients who need help. We are refusing almost 60% of the inquiries which are coming, because they are not eligible. Many of them are type 1 diabetics. So type 1 diabetes, this surgery doesn't work. So we outrightly refuse them. A large number of them are below 27.5 BMI. And the challenge is, I got a gentleman who came from South India recently. He could not get an appointment, just walked into the OPD, a senior 72-year-old person with HbA1c of 13, and his BMI was 25. And he says, "Doctor, if I tell you to operate me with all the risk I will take, will the surgery not work for you? Work for me, for him?" And I said, "I know the surgery will work for you. We knew it when the cutoff was 35 BMI. We knew it that this will work on 29 BMI also. But we never offered below 35 BMI. Now I know it will work on 25 BMI also, but I cannot offer because the guidelines say so." And it's an awkward situation that a senior man, 72-year-old man, starts crying in front of you that you are giving him up. Then he says, "Then that means there is no hope for me." Now, what do you do? And Shithil, it's a challenging situation. It's not a question of whom we operate. The question is whom we refuse. And that's a majority. 60% of patients at the moment we are refusing surgery because they don't fit the bill. But that's the challenge of following science.
Thank you for that answer. One of the comments that I would like to read is from Dr. Monica Dhawan. She says, "Thanks, sir. Never knew such benefits. Keen on learning bariatric surgery after listening to your talk." So taking that same question forward, so looking at that, so what do you think about the future of diabetes surgery? Please answer it for the young surgeons who wish to pursue diabetes surgery.
Yeah. So, Monica, if you are a surgeon, there are plenty of opportunities to learn all over the country. There are about 20 centers of excellence across the country. Not everyone has started at the moment, but I'm sure they will all gear up. We are all same kind of surgeons. They will also start implementing these protocols soon. So you can go to any of these centers or you can approach us. We have a university fellowship, 1-year fellowship program, Maharashtra University of Health Sciences approved fellowship program. We also have the COE fellowship program. You can spend 1 year if you can get time, if you're a young surgeon. If you are already established in practice and cannot spare 1 year, maybe you can come for shorter duration of 2 weeks to a month and learn, because any advanced laparoscopic surgeon can quickly pick it up. Of course, you cannot be a master in 1 month, but if you want to have a mastery, spend at least a year. There are many opportunities. You can write to Doc Plexus and they will get back to me, or you can contact me directly. It's so easy to find out on the Google, and directly message me. For doctors, I'm directly available on my phone, and call me anytime.
There is a follow-up question from her. She wants to know which surgery is of gold standard, sleeve or bypass.
Monica, without any doubt, it's a Roux-en-Y gastric bypass, and we are doing our training program on 1st March, just before our national conference in Mumbai, on Roux-en-Y gastric bypass, where I'm taking precisely this talk on why Roux-en-Y gastric bypass remains the gold standard of bariatric surgery. So if you are interested, please, I'm sure you are coming for the OSCON from 2nd March. You register for that program, and we'll explain in detail.
Thank you for that answer. Now moving on to the next question now. So my next question to you is, how would one determine if the patient needs a diabetes surgery? What things he or she should have tried before deciding to go for a diabetes surgery?
Okay, Sheetal, it's a very important question. As I mentioned, that patients who are not on medication are not being offered this surgery, because we are not curing diabetes. I am only giving better control. So if they can be controlled with medicine, they must remain on medicine. If they are controlled, if they are not getting controlled with medicine, then they can, then and then only they should think for surgery. Now, what medicine? It is between his physician or her physician and the patient. If the physician believes that I am giving the best possible medication and the diabetes is not getting controlled, then that is the time when you should operate. It could be only oral hypoglycemic. It is not necessary that only those patients who are on insulin should undergo surgery. No. Optimum medical management, the guideline says. So optimum medical management could be only oral hypoglycemics, and if in the physician's opinion the sugars are not getting controlled with that, the surgery can be offered.
Thank you for that answer. How long should have the patient tried medicine? Is there a cutoff for that?
No, there is no cutoff for that. This is the word that is used as optimum medical management. So let me say it other way, going beyond the guidelines. It has been established that those patients who come early have better remission rates. Control is there in all the patients. Even if you come after 20 years of diabetes, the control is similar. That means the HbA1c come down. But remission, that means all the medicines will stop, happens in those who come early. So it's not necessary for patients to wait for 5 years before they are given a certificate that they can have a surgery. Like I mentioned, the lady in the end who is a psychologist here, she got it done at 1.5 years, even though she was only on oral hypoglycemic, because she read the literature and she said, if I will get it now, I'll probably not need medicines lifelong. So earlier, the better. But even those who are coming late will definitely benefit from it. And that is the key. The key is not stopping the medicine. The key is blood sugar control.
Thank you for answering that. We have our question from Dr. Prabhu Shankar. So he wants to know, you have already spoken about this in the session. So is there a difference in type of surgeries while selecting patients with type 1 and type 2 diabetes mellitus?
Dr. Prabhu, we don't treat type 1 diabetes through this kind of surgery. Type 1 diabetes can probably require a pancreatic transplant, which I am not competent to do it. There's a transplant surgeon who does that. So for within type 2 diabetes, there are 3 types of surgeries, as I mentioned: sleeve gastrectomy, Roux-en-Y gastric bypass, and one anastomosis gastric bypass. This is a this is a call that surgeon has to do after seeing multiple factors. So we want to see pancreatic function at the moment when the patient comes to us. We want to see for how many years the patient is diabetic. We want to see for how many years patient is on insulin. Now, there are various remission scales that we use to calculate, find this out, and it's quite a scientific way of deciding. But ultimately, it also depends on patient's choice. So we tell them that I will prefer a Roux-en-Y gastric bypass over a sleeve. But if patient says I only want one anastomosis gastric bypass, then obviously it's patient's body. Diabetes remission is almost similar in first 5 years with all the three procedures. But then in long run, gastric bypass definitely scores over sleeve, especially in those patients for long who have diabetes for long duration. So I think there are various permutation and combinations, and let's leave it to the surgeon to decide or suggest.
Thank you for that answer. Moving on to the next question. Next question is by Iftikhar Khan. So he wants to know the cost of this surgery.
Dr. Khan, fortunately, now these surgeries are covered under insurance. Okay. So from October 2020, all metabolic surgeries are covered under insurance. The only problem is this is covered as per the old guidelines. That means 35 BMI with uncontrolled diabetes. It took the bariatric community 20 years to get it approved by insurance. We started somewhere in 1998, and 2020 we got approval under insurance. So getting the guidelines changed to 27.5 BMI might take another 5-7 years. So those who are insured, it will be covered. The entire expenses are borne under the insurance. But those who are not insured, please believe me, the cost of surgery can be recovered within 1.5 years of your medical management, or within 4 hours if somebody gets a cardiac episode. When somebody gets a myocardial infarction middle of night, you end up spending 4 lakh rupees on the stents that are placed in, and without these questions asked about how much is the cost. I don't think the cost of the surgery is too much. It's quite reasonable. And if you see the cost benefit ratio, it is certainly much less than the cost of living with diabetes or facing the complications of diabetes.
Thank you for answering that. My next question to you is somewhat related to the insurance. I know you're not an expert about this, but do let us know about the policies that actually cover these bariatric surgeries as such, which could help the patients out to buy these policies beforehand, and they probably at deciding whenever they're going for a weight loss thing.
All the insurance companies cover bariatric and metabolic surgeries. There are certain conditions about BMI cutoff. As I said, for diabetes, it's 35 BMI. But overall, if somebody has a policy for at least 3 years, that means he has paid the 4th premium, then these policies cover. Now, the question you are asking is, what we should buy. There are certain insurance companies which restrict the amount they will pay for a bariatric or metabolic surgery more as the inflation goes up. So not at all. It's not a great recognition that India, the problem that country is facing. The only thing that can protect this country from diabetes menace is health awareness, regular exercises, yoga, eating healthy in restaurants, eating healthy at home. So I think
of this diabetes surgery, what other surgeries can be avoided?
I think, broadly speaking, renal transplants can be avoided. If the person doesn't have a nephropathy when they come to you. So that's why if they come early, before they start having comorbidities, renal failures can be avoided. End-stage renal disease happens in 50% of patients with end-stage renal disease have diabetes history. cardiac surgeries can be reduced. The load of cardiac surgeries. I mean, I have data to say that even those who had a angioplasties in past or had a CABG, if they have a diabetes surgery, it will reduce the possibility of a second or third episode. So cardiac surgery can be avoided. I mean, there can be surgery for GERD that can be avoided if you do a proper bariatric surgery or metabolic surgery. So I think it's a very long list. There are cancers which can be avoided if we do a bariatric or metabolic surgery. So I don't think we can make a list of what surgeries can be prevented, but whoever asked this question has given me something to think about. I'll make a list and share it with you one day.
Sure, sir. We'll be happy to share it across Docplexus.
Thank you.
So my next question to you is, there was a paper in one of the studies. It was found that after bariatric surgery, patients with type 2 diabetes mellitus remain at risk for developing sight-threatening diabetic retinopathy. Even those who did not have evidence of diabetic retinopathy before surgery. So do you advise routine eye checkup for patients post-surgery?
We are not advising that for sure at the moment. But as we are learning, we realize there are certain microvascular complications which are like autonomous complications. So somebody who has a diabetic retinopathy or a diabetic nephropathy, irrespective of glycemic control, may still continue to worsen. And that is why it's necessary that these patients are under close lifelong monitoring to avoid such problems. But on the other side, there is overwhelming evidence, as I have shown you today, that these complications can be reduced. So I think a balance in long-term follow-up, regular checkups. If diabetic retinopathy is being checked in every diabetic patient, even if they don't have eye symptoms, by physicians, if it's a part of protocol, we'll inculcate it as part of surgical follow-up protocol also. But it's very difficult to say that this is happening in only surgical patients. Okay, you understand what I'm saying? If medically managed patients without eye symptoms, are they also undergoing eye checkup for retinopathy as a matter of routine by everybody? Then we'll inculcate it. But I do not see any reason to say that this will happen only after surgery and will not happen with medical management.
Thank you for answering that. Now moving on to the next question. So my next question is, what are the complications that can occur after diabetes surgery, which the surgeon has to be careful about?
Okay. So there are two types of things or three types of things that we are looking for. Surgery-specific complication, diabetes-related complications, and diabetes comorbidity-related complications. Because everything that happens after surgery will be ultimately pointed towards surgery, as you just mentioned about retinopathy after surgery. So initial complications after surgery are the same that can happen in bariatric surgery. But now the incidence have gone down so much that we do not even arrange blood for this surgery in almost all patients. So that means the blood loss is between 50 to 100 cc, okay, or even less in most of the patients. The complications of leaks have gone down significantly as the technology of staplers and our techniques have improved. The infections in hospital, patients have this mortal fear that I am diabetic. If I get operated, there is a high possibility of infection. But the hospitals, like where I work, are so advanced. The operation theaters are so sterilized that we hardly see one patient of infection in a year, and these are also minor infections. There are no life-threatening infections happening. So I do not think Obviously, no surgeon, no sane surgeon will give guarantees, but the possibility of complications, surgical complications, have gone down drastically over the last 25 years.
Thank you
Now,
for
the
that
second-
answer.
I'll
Sir,
let me
please go.
finish.
Please go ahead.
Diabetes complications. Diabetes thing is that we need to identify patients where sugars are not controlled. So what happens, Shithil, is that patients start believing, we have not told them, patients start believing that their diabetes is cured because they check it. Each time they check it, it comes normal range. And when they check it for 2 to 3 years, they stop checking. Because they said, what is the use of checking when it always comes normal? That is the danger period. So we need to be careful about that. We need to keep on telling patient, please check your HbA1c regularly. And third thing is, as you mentioned about retinopathy, there are certain autonomous complications of diabetes in those who already have it when they come to us. We should be watchful of that because patients will start believing that they may not have any complication because they have good glycemic control. But those are the things which we need to be careful. And the patient is asked to follow up with their physicians after surgery. We ask them to continue to follow up with their physicians because they are closer to the patient, they know the patient better, and they can identify these symptoms earlier. I mean, somebody from Ranchi may not be able to come to Mumbai every time, but they can go to their neighborhood physician and get them treated or get them identified with these complications.
Thank you for that answer. We'll just take one last question now. So my last question to you is, what would be a surgeon or physician's responsible role and responsibility post-surgery for a successful weight loss regime?
I think it's a multidisciplinary team approach. And we always work with the patient's physician to ensure that the outcome is better. I do not get away from the being responsible for patient's care, even if the physician is managing the patient. It's very important to realize and keep the patient in their regular follow-ups. So patients are asked to do these tests on a routine basis, which is not like HbA1c is 3 monthly, but annual checkup is only once a year. And since majority of our patients travel long distances to come to Mumbai for surgeries, they are followed online and they are told. So we stay in touch with their own physicians and we work together to ensure. But I think it's a collective responsibility, not only of the physician and surgeon, but even of the patient. If they start having gulab jamuns and laddus every day, pastries, then there is so they are as much a partner as they are as much a treating person as a doctor, as a surgeon or as a physician.
Thank you so much, Dr. Raman, for that wonderful session. This brings us to the end of this session. It was absolutely wonderful listening to you. Thank you, Dr. Goel, for your time and effort in putting together this interesting session. To our dear viewers, thank you for attending this session. Do share any more questions if you have. Until we see you again, take care and happy docplexing. Thank you.
Okay, take care. Thank you, Dr. Lexus, for this. Thank you, Dr. Shithil.
Dr. Raman.